Do you have a patient with low back pain that gets irritated with bending, sitting, or driving? Maybe their symptoms shoot down their legs? If so, you might be dealing with a discogenic pain condition, and there's a specific type of exercise that can often bring rapid relief. So today, we're diving into targeted rehab strategies to help you guide your patient toward real, lasting relief. Patients with discogenic low back pain often present with low back pain that refers or radiates into the legs, and is typically aggravated by flexion-based activities like bending or sitting. They commonly report morning stiffness in the low back, along with reduced lumbar lordosis, leading to limited lumbar extension. Sciatic-type symptoms such as radiating leg pain, numbness, or weakness may also be present, although not always. A key finding in these patients is something called a directional preference, essentially a specific movement or sustained posture that eases or reduces their symptoms. This is an important factor to identify in all of your low back pain patients, as it can really accelerate their recovery. Because research shows that when patients have a directional preference and receive exercises tailored to that direction, they experience significant improvements in pain and disability compared to those who just receive general manipulation or exercise. And the large majority of these patients tend to respond to an extension-biased approach, also known as the McKenzie method. Now, we're not going to cover every single technique from the McKenzie approach, but we will focus on some of the more key concepts that will help you and your patients manage most situations. So in this video, we'll be emphasizing more of the home-based exercises that patients can easily perform. So let's take a look at a progressive, evidence-based strategy designed to help your patients regain control over their symptoms so you're not constantly battling pain every time they come in. But before we can get into specific exercise, we must go over some of the more important guidelines to guide decision-making. And make sure you don't keep this information to yourself. Educating patients on these principles is key because it will directly guide how they perform their exercises at home. When patients understand the rationale behind these guidelines, they feel more empowered and are better equipped to take charge of their recovery, which will make a real difference in their compliance and ultimately their progress. Number 1, pain during movement. It's completely normal for patients to experience some low back discomfort during these exercises, especially in maximal extension. It's essential to communicate that this discomfort is not harmful and should actually improve the more they perform the exercise. Number 2, how to progress. We'll be working through a series of exercises, each progressively more challenging. If patients find relief with a particular level, then there's no need to move on until that relief plateaus. Only progress if symptoms return or aren't fully resolved. Number 3, dosage and frequency. Aim for a minimum of 3 minutes for a static exercise and 10 repetitions for a dynamic exercise, with a brief rest in between each rep. Encourage a minimum of 4 sets per day or as needed for relief. You can equate these exercises as a non-pharmacological way to manage pain. Number 4, symptom monitoring. It's essential for you and your patient to keep a close eye on symptoms during and after exercise. Help your patient learn how to assess their pain levels in the specific location of their symptoms before and after. If they notice a reduction in symptoms or if the pain centralizes, meaning it moves closer to the spine, that's a great sign. It suggests that the movement is appropriate and in line with their directional preference. Keeping track of these changes is key in guiding the recovery process. And number 5, when to regress. If the exercise increases peripheral symptoms, this suggests it's time to revert to a less intense movement. Should the patient struggle to find an effective movement despite decreasing intensity, encourage them to explore different movements instead. Okay, let's get into the exercises now. The first step in the extension bias progression is to start with the patient lying face down or prone. Now, it might seem like they're not actually doing much, but this position can be a great introduction, especially for those with a kyphotic deformity who struggle with extension. Here's how to set it up. Have the patient lie down with their head turned to one side and encourage them to relax in this position for up to 3 minutes, letting their lower back gently sag into extension. But if a patient has a severe enough kyphotic deformity that makes it significantly uncomfortable for them to lie flat, consider placing 1 or more pillows under their abdomen for support. This little adjustment can make a big difference. After a couple of minutes, they can start to remove the pillows gradually, working their way toward full prone position. It's all about easing into it. Now, if they can tolerate full prone lying for 3 minutes without an increase in low back pain, it's time for step 2. Next, we'll progress to the second procedure, prone lying and extension. This step builds on the first one by enhancing the extension effect through sustained positioning. If the patient has trouble tolerating it, encourage them to take breaks and return to lying prone at regular intervals. To begin, have the patient lie prone on the bed. They should position their elbows under their shoulders, using their elbows and forearms for support, while keeping their hips and pelvis flat on the bed. This setup allows them to relax and lets their lower back sag into deeper degrees of extension. They should hold this position for 3 minutes or sometimes longer if needed. But if they start to feel uncomfortable, they can return to flat prone lying if needed. If they can tolerate 3 minutes of prone lying and extension, it's time to move on to step 3. Once the patient has successfully performed the basic extension and lying several times and is comfortable, we can progress to the full range of extension. The patient starts in the same prone position with their hands palm down under their shoulders. Have them lift up the top half of their body by straightening their arms while keeping their pelvis on the table. To get the most effect, have them lock out their elbows, breathe out, and allow their pelvis to sag. They'll maintain this position for 1 to 2 seconds before returning to neutral. The patient should repeat this rhythmic movement for 10 repetitions, aiming to reach the end range of motion with each repetition. Now, this technique can be repeated for multiple sets if the patient continues to report improvement in symptoms. After all, if it works, keep going. This movement is one of the most effective exercises for treating derangements that respond to extension principles and extension dysfunctions. So you want to progress the patient as fast as you can to this step. So make sure you introduce this movement as early as possible, often starting on day 1. The more extension we can get, the better. Now, if your patient stops responding to the extension and lying, it might be time to step up the intensity a bit. While the McKenzie approach does suggest other ways of applying pressure to the back through straps or manual contact from the therapist, these setups can be tricky to manage at home. Instead, a simpler way to increase intensity is to add a lateral force to the usual extension movement. This adjustment can be especially useful for derangements that aren't improving with straight plane movements alone. For this exercise, have the patient start in the same prone lying position, with their hands palms down under their shoulders. Next, the patient shifts their hips slightly off center, usually moving the hips away from the painful side. For instance, if the pain is on the right side, the hips will be positioned to the left. Then the patient raises their upper body by straightening their arms while keeping the pelvis and thighs relaxed. They hold this position for 1 to 2 seconds before returning to neutral. Have the patient repeat this movement in a rhythmic fashion, aiming to reach further with each repetition, up to a total of 10 times. Now, when a patient does this, you'll notice that they start to straighten out with more repetitions. So a helpful trick to keep them from doing this is to have them hook the foot on the same side as the side they're shifting towards over the edge of the table or bed. Now, as we mentioned, we want our patients to do this repeated movement frequently throughout the day to control their symptoms. But what happens if they're at work or a place where they can't lay down? Well, this technique can also be done in standing. To start this exercise, have the patient stand with their feet shoulder width apart and place their hands on the small of their back. Using their hands as a fulcrum, they'll gently lean backwards as far as they can go. They should hold this position for 1 to 2 seconds before returning to neutral. Have them repeat this movement rhythmically, trying to reach further and further with each repetition. Now, it's unlikely that the standing exercise will fully reduce symptoms on its own, but it serves as a useful supplement to the lying extensions to keep pain at bay. And that's it, an effective exercise progression for treating patients with discogenic pain who respond well to extension. I hope these techniques help you in managing discogenic pain more effectively. Just remember to tailor each step to your patient's comfort and how their symptoms respond. And if you found this video helpful, don't forget to give it a like and subscribe to the channel so you can stay updated with more tips and clinical insights.